Hello, everyone, and welcome to the AI Talk Series with Neutigers, a show where we explore the benefits of Edge AI. I am Stan Bertolut, VP of Growth here at Neutigers. Neutiger productizes and commercializes exclusive AI IP algorithms from Princeton University. We enable smart applications at scale for the intelligent edge network in the healthcare, industrial IoT, and cybersecurity sectors. I see that we already have quite a number of attendees. So welcome everyone, and please introduce yourself. Let us know where you are connecting from using the chat panel on LinkedIn or on YouTube. We are in for a fascinating discussion today. And I know that you will have questions. I encourage you to ask them throughout our conversation using the panel that your social media platform provide, again, on YouTube or on LinkedIn. So when we talk about biases in AI, we often blame insufficient training data. Indeed, in order to correctly train an AI model, you need a large quantity of quality data. Yet, is data the only problem? This is what we are going to be talking about today with our guest, who is passionate about eradicating biases from healthcare data collection. At the Cincinnati Children's Hospital Medical Center, she is the co-director of Faculty Diversity, Equity, and Inclusion. She has researched and published studies on biases in clinical settings. She joined us today to help us understand our role and responsibility as we think of developing artificial intelligence model. For her, the challenge we face aren't just technological, they are above all human. Let me introduce, sorry, I'm struggling with this. Hey, welcome to the show, Jareen Meinzen-Derr. Can you please introduce yourself?
Yeah, so I'm Jareen Meinzen-Derr. I am a quantitative epidemiologist by training. I am a professor of pediatrics at Cincinnati Children's Hospital Medical Center, as Stan said, the co-director of Faculty Diversity, Equity, Inclusion, as well as the co-director of the Center for Clinical and Translational Science and Training.
So when we prepared this discussion, Jareen, you wanted to stress that you were not here in support or to batch AI. Do you want to say a little bit more about that?
Yeah, so I think when I tend to give these kinds of talks or have these kinds of discussions around AI and the bias in the data, it isn't an anti-AI talk at all. In fact, I consider AI a valuable tool that, just like all of the other valuable tools that we have in the data science and statistical world. My goal is really to focus and bring awareness of the bias that tends to be in the data that AI tools use. And that's where I want to kind of keep the focus on.
Okay, all right. So let's start with a basic definition of what is biases for you.
Okay. So in research and in research terms, since that's sort of the lens that I wear, bias is a systematic error in the study that actually results in an incorrect estimate of the association that we see between the outcome of our interest and the exposure or the predictor that we're interested in. And it is usually split or classified as information bias. So the bias in the information that we're collecting about individuals, or selection bias, which is bias in the individuals, the participants, who we actually have as part of our study. And these are they are errors, and they are factors that tend to stick with the study from beginning to the end of the study and are very hard to remove once they're embedded in the actual study. And since artificial intelligence, as well as any statistical model, uses data that's already collected, that the bias is already ingrained in that data that we collect. And so it's very hard to mitigate it at that stage.
Right. And I think, again, this is part of the discussion we had, Jareen. Neutiger develop algorithm, right? Our role is to be a software provider of AI solution. And we are totally conscious of this problem that biases is. And this is why, as we are working together with Cincinnati Children's Hospital on the sickle cell research that we are conducting, that we became aware of your interest for biases, and we went like, how can we be better at what we do? How can we be more conscious of the problem, and and try to see how we can do a better job at developing less biased model. And this is really something that we are going to be talking about today. Is it possible to tend to be unbiased? Right. I think, since humans are human, this has been a question, a philosophical debate. And this is what we are going to be touching on today. How feasible is it to reach an unbiased solution system? And here we are talking AI, but as you are going to be talking about, your job has not been only focused on AI, right? It has been about collecting data in healthcare studies. And I think it's going to be very interesting to hear your views on that. Do you want to give us a 1,000-foot view of how algorithms affect the life of a patient in the medical care that they receive?
Yeah, so there's a lot of opportunities for AI in the healthcare setting that has improved either the actual health and well-being of individuals or the quality of life of individuals. And you and I sort of mentioned a couple of these earlier. One would be brain-computer interfaces that allow people better connection with the world when they can no longer be mobile and do so. There are next generation radiology tools and more precise analytics for pathology. So which have in fact improved our ability to identify either diseases or disease processes. We can think about how AI can expand care to rural parts of countries and allow better access and provide better care to those other areas that have accessibility problems coming to a hospital setting or a city. And then advancing the use of immunology care for an immunology treatment for cancer. I mean, there's a lot of opportunities where AI has in fact impacted positively and improved the health and well-being of patients.
Right. And I was mentioning the sickle cell disease, which is a disease that really touch the population of Black American in the US, or the African population and Caribbean population. And people with the sickle cell disease have what we call VOCs, extremely acute crisis that can end up in putting the patient in a clinical coma because they are so painful. So what we are trying to design at Neutiger, and a study that we are conducting in Europe, is how a model based on data gathered by smartwatches, so interpreting the physiological condition of a patient, can predict the emergence of those crises in order to guide the patient into better lifestyle, or just relax if the person is stressed, or stop a very stringent activity, physical activity, in order to try to keep the patient from developing that crisis. So that's another example of the use of AI. But again, let's go back to biases, because all that mean that the patient is going to be, he or she is going to be wearing a watch. How are that person, those person, going to be welcoming the fact of wearing a watch all day? That is a question that we're asking ourselves. You've published a study in the Journal of Clinical and Translational Science on training machine learning model on electronic health record. Can you tell us a little bit about the finding of those studies?
Yeah, that particular paper was really meant to be provide some guidelines and some guideposts for individuals who are interested in designing studies that use machine learning, which is a subset of AI, for the purpose of with electronic health record data, for the purpose of prediction modeling, as an example. And so this really walks an individual through the different considerations that we have to take before we jump right in and build a model. And so part of those considerations is around the actual healthcare data itself. And I think one of the primary points that we really need to think about when we're thinking about healthcare data is the purpose of healthcare data. And the purpose of healthcare data has never been about research. It has been about a longitudinal collection of data for the purpose of health care, for the purpose of health care delivery, for the purpose of documenting for physicians, and for the purpose of billing practices. And nowhere in that sort of provision of knowledge and decision support that is meant to enhance the quality and safety and efficacy of patient care is research part of it. It was never meant to be a consideration when it came to healthcare data. And so the important sort of lesson around of one of several lessons around the paper was just bringing that awareness that when we're using healthcare data, we're using data that is never meant to provide us with answers around, in the research realm.
So how did you, I mean, what can we take away from that? Because at the end of the day, you are saying those data were not made to be used in research, but yet they are used in research. So what is the outcome of that? What happened when you are using data which were not designed to be used in that context?
Sometimes good things and sometimes not so good things. So when we think about, I had said this earlier around healthcare and around humans, and that humans are part of this complex, nonlinear, and chaotic system. And it's inconsistent. It has inconsistent predictive relationships with anything, and it makes it very difficult to be consistent with our findings often. It is often why we're repeating studies over and over and over again, because our studies sometimes come up with inconsistent findings or not very accurate findings. High quality data sources tends to be a gold standard, and it is why the original sort of observational epidemiologic studies, randomized controlled trials really try to achieve that, where they get the data as accurate as possible with no measurement error, where people behave as similarly as possible, and then again, there is no bias. Healthcare data doesn't have any of those components actually in there. There are some things, of course, that we can do, but they are really just Band-Aids, and they may help minimize some of the bias that we have, but they don't remove it. And I think that the important point in the paper was there are some things that we can do and that we have to be careful about, that we can try. But we have to also always interpret our findings in the context of this data may in fact have biases in them, and identify what those biases are up front.
Right. So would you concur in saying that AI biases is not always a consequence of limited training data, to a certain extent that we human all carry unconscious bias and behave accordingly?
So if your question is around, if you're asking, is it because of limited training data? I do think that it is important that we have good, decent training data. It has to have a large enough sample size. It has to be as complete as possible, and it has to be as accurate as possible. So the errors need to have been fixed or removed in training data, obviously. But if the training data are biased, then those biases are going to carry out throughout that entire model. And so even once you validate that model, those biases are still part of that final model.
Right. Right. So as we were discussing this topic internally, I was talking with our CMO, Chief Medical Officer, Greg Nicola, and Greg told me that one of the questions we have to ask ourselves is who is designing a model, an algorithm, in which context and for which purpose. So this, tend to go to the fact that we need a diverse team. Let's say you want to solve a problem for a certain category of the population. Are you the best person to design that algorithm? Should you be advised, or should you have in your team people from a certain community, a certain part of the population in the design process? What's your thought on that?
You made me smile really big, if you couldn't tell. Yes, I love the concept of diverse teams. I don't think that is limited to a team around artificial intelligence or model building. I think that all research should have diverse teams, and that's not just diversity of expertise. We're talking diversity of thought, because you always want to be pushed, but also diversity of lived experience, because I do feel that part of our biases are those lived experiences. And if we all have a similar lived experience, it's very impossible for us, or improbable for us, to step into somebody else's shoes and think about what that other person's experience may be, especially if no one at the table has a different experience. So diversity of lived experience is vital to our ability to understand how we do something correctly, and the results that we get, because in the end, it's about the interpretation. So I absolutely agree with you. And one of the things that I've actually been talking about over the past few years is around the concept of bringing in more social scientists to the table to talk to us and to help us understand the work that we're doing, in the context of a real world scenario. So I fully agree with him about diverse teams.
Yes, and maybe this is something that we are going to be covering up in other question, but I wanted you to talk to us about the context in which questions are being asked, the physical context, but also who is asking question in medical interviews. But before we do that, I want to remind everybody that this is an open conversation. We would welcome your question if you have any, and I'm sure you have tons of questions. So feel free to use the chat panel and to ask any question to Jareen or to I. We will be happy to take them. So yes, as we were talking about designing questionnaire and asking question to the patient, you were saying that the context in which those questions are gathered is important. You were mentioning obviously the physical exam, where the physician can ask you, how much do you drink, do you smoke? Do you want to go back to that example and the importance of it?
Yeah, it's actually an example that I use when I am talking about bias and information bias in my epidemiology class. In research studies, you have an opportunity to design all of your questions in a way that try to elicit the answer in the same way from everyone. And you train people to ask those questions in a specific way, so that the person who's asking the question doesn't come off as judgmental, tries to relieve any bias they may have on the participant when they're asking a question. The training that happens Well, the purpose of those questions for research are very different than the purpose of those questions for, in a healthcare setting. So when someone enters their physician's office, they're going to be asked a series of questions by the physician or on a questionnaire. And the drinking one came up recently because I had a doctor's appointment in November and I filled out a questionnaire, and on their questionnaire had how many times do you drink a week? How many drinks do you have a week? And I wrote a number in. We will keep that number quiet. But apparently it was different than the number I wrote in last time I was there. And when I walked into the doctor's office, the doctor mentioned it to me. And I all of a sudden felt embarrassed. And so clearly the number was a little more than I had admitted in the first time. And then I admitted, oh yeah, I lied last time because I felt that I would be judged by the number that I wrote down. And in fact, if those questions are even being asked, I was on a paper. So I wasn't even being asked those questions. But when somebody is asking you a question, how many times do you smoke? We know smoking's bad. And now you're asking me how many packs I might smoke in a week. And I know you think it's bad. And I know you're going to give me the lecture. So I'm going to lie. I'm going to minimize. I'm going to tell you something different. Same with eating habits, same with exercise habits, same with drinking habits. So yes, we feel judgment on a lot of the questions that make us feel like we have to answer differently. The person asking us may in fact impart judgment or bias about what they think we should be doing or what we are doing. And that interaction plays out in the electronic health record. So either there's a note about how I may have acted in the electronic health record. The number itself may have a star that says this, I think this is more, I think this is less, and that number is not a valid indicator of what I'm really truly doing. And it in fact impacts our ability to make connections between exposures and outcomes because that data are not valid because of the biases that I may have felt or may be providing to somebody else. That's a long-winded answer to that question, but yes.
No, it's fascinating. And you also mentioned the fact that those questions are being asked in a clinical context, right?
Yes. So I can state that they're asked in a clinical context. And if they're not asked, usually in research, the assumption is, if it wasn't asked, it was, it's not documented, not done. So we assume that if something's not documented in research, then that's a true missing. But in the clinical setting, that's not always the case. There may be reasons why something's not documented. It doesn't necessarily mean, it just may have been a moment in which that question was not important. And so it's hard to understand the context of missing data in a healthcare setting because we don't know the context in which that data was or was not collected. And that makes it even messier.
And what do you think of using electronic monitoring device? Would that remove part of the biases? Let's take, the simple example of a Fitbit, a step monitoring solution. And all of a sudden, your physician knows exactly how much exercise you take every day.
So using basic study design and EPI principles, going back to those, objective data is always sort of the best data to have from the perspective of it being more valid and reliable than subjective data. And so anytime we can have an opportunity to collect objective data, even if it's to validate our subjective data, it's a good practice. But you and I also talked about, Stan, how sometimes those Fitbits may not, in fact, or wearable devices may, in fact, not accurately capture data correctly.
Yes, and I think you are referring to one of the findings we did as we design our model to measure whether someone has COVID-19 or has not COVID-19. We are using a smartwatch with various sensors, and we realized that one of the sensors is using light to go through the skin. And people with darker skin have the skin let less of the light go through. So we had to adapt our model through that. And again, it speaks to the diversity of the data we collect to make sure that we are aware of all those variation in order to take that into account. So, as we designed the model, we had to adapt that to various population to make sure that worked very well. Let me, still on the subject of AI, we often hear that AI is a black box. Yet, don't you think that the only black box is actually the human algorithm? Changing an algorithm is quite easier than changing people's mind. Software on computer can be updated compared to the intransigence of human biases. Fixing an AI model seems way simpler. What do you think?
Yeah, than fixing humans. I I think that yes. So first off, you're correct. Fixing, tweaking, refining AI models. Any model is simpler than trying to change and shift the human nature. I will say absolutely. But one of the things that I also want to bring sort of to the forefront of our minds is that when we put a model out, when we publish on our findings, when we want to implement something that we have discovered for the purpose of uh, improving, the health and well-being of individuals, if that model's wrong, we're at high risk of causing harm. And I always feel as a methodologist that, we're sort of this last line of defense between what we find and actually changing practice and actually, exposing people to something. And so we want to be, extremely cautious about what we put out there. And so if the AI model is wrong, sure, we can tweak it and fix it. But if we put out something that is wrong and people adopt it into practice, we actually can cause harm. And there have been a number of instances that are coming up in the literature in actually medical practice where predictive models have been inappropriate and inaccurately predicting outcomes and have in fact shifted practice and care for a whole slew of individuals. And so we want to be absolutely certain that what we put out there does not cause harm and continuously monitor. I think that's the other piece is when we have a prediction model or have a model, we want to continuously monitor that model. And right now, these models don't have any governance structure or modeling oversight. Once they're in place, they're in place. And so thinking about that, I think, is critical. It's vital to the health and well-being of individuals.
Right, right. And this is one of the reasons why we decided to have this conversation with you in order to be and really to bring awareness in the AI community of the importance of keeping track of the model we put out there and being able to modify those models if need be. One of the questions I had for you is on the use of synthetic data. Synthetic data is something that Neutiger is interested in, not just interested in, but we actually have a solution to generate synthetic data. And we often read that synthetic data is sort of the magical solution to biasism. If you don't have enough data, why don't you generate more of that missing data? If you know that the data might be biased, why don't you correct it and then generate more of the good quality, real world like data? It seems to be quite a magical solution to this problem. And in fact, the Gartner Group, said that in 2024, I believe 60% of the model will be trained on synthetic data. What's your take on that?
Well, we had this discussion yesterday, and of course, every cell in my body just buzzed and cringed, thinking thinking about that. I don't think developing synthetic data for the purpose of removing bias actually is a solution to the problem. I think that there are times in which we do statistical measures that help us fill in the gaps in our data. So, we do a lot of imputation and multiple imputation methods to try to fill in the holes when data are missing. We try to figure out how to remove some of the extreme outliers and, kind of give our data as much of a haircut as possible so that it looks presentable for our model. I'm not entirely sure that adopting a practice of using nothing but synthetic data will actually get us to the truth, because the data, in fact, are synthetic. They aren't really showing us what's really happening. And I actually might think about challenging us to focus more on the efforts that improve the circumstances that lead to the biased data, as opposed to figuring out how to fix the problem at the end game. Because by the time we're at the AI component, by the time we're at model creation, that's the end game. We're at the end. We're about ready to fly through the gates. And what we need to do is, how do we actually change the circumstances that where that led to the derivation of biased data? And I think that's where we need to be putting our efforts in.
Right. So let me bring up one question that we got here. And so I just want to summarize what you said. I mean, synthetic data might be part of the solution, but the real problem is, how do we generate data which is not biased, how we design the questionnaire, how we bring together a diverse team that will think differently of the problem we are trying to solve. So am I right?
And I might also add and take it one step further, which is probably one step before the data scientists get fully involved. But something that I want all data scientists to really think about is not just about how we collect that data and not just about how we ask those questions, but also about thinking about breaking down the systems that are in place in our society that help with continuously generating that biased data. And we're talking about a lot of systemic oppression. And if we're talking about healthcare, that really do play into the data that are collected in healthcare. So as data scientists, like I said, we're at the end game when data are collected, but I would love for us to think critically about how that data got there, where it came from, and what went wrong in this process that brought it to us that will in fact make it biased. And then how do we break those structures down?
Okay, I get it. And it's definitely not something that will happen overnight, right?
No.
So let me bring back that question again from LinkedIn.
Yes.
Question from Omid. I let you read it.
In terms of oversight for these models, would this be more effective to come from the healthcare stakeholders, such as hospitals and physicians, the AI companies themselves, governments, or a combination of all of the above? That's a great question. I think the oversight needs to come from multiple places, multiple people. So this is actually a great example of a diverse team that is necessary for oversight. I might also add that oversight for these models might also be important to include the patients themselves, the people who actually contribute to the data, because we do very little about involving them in what we want to do and how we want to do it. And they have a lot to say about this. And one of the things I've always said is, this data we're using, it never belonged to us. It always belonged to patients. And so we should think about them in when we're thinking about oversight, when we're thinking about important questions to answer. So absolutely.
Thank you, Omid, for your question. And to all attendees out there, feel free to ask more questions. It's really interesting what you said, Jareen, about involving the patient. And And again, to brag a little bit about what we're doing here at Neutigers, I was, referring to the studies on sickle cell. Well, the lead developer and researcher at Neutiger is an actual patient, someone who has sickle cell and who is leading this effort. So, I think his awareness of the condition of what it is to live with that disease has really made a tremendous difference in how we tackle that problem. So you are 100% right here, and he's really guiding us and directing us as we are building this study. We are getting at the end of this discussion, and I'm wondering, Jareen, is it possible to build an unbiased AI model?
That is all right. So that's a great question. That's the $100,000 question right there. If you're asking, is it possible to build an 100% unbiased model? And I would say no. I think that it's not possible, but simply because sometimes we don't know or recognize the biases. There are a lot of unmeasured things that happen that bias and confound our data that we don't recognize nor understand. So to that, I'm going to say it's not possible. I do think it's possible to get close to the truth, to minimize error, to try to narrow, our field of, our scope of field to get to the truth. I think if we could get right to the truth, which would be the unbiased answer, we would have been there. And I don't think we're anywhere near there for nearly any question we have. But I think we should strive, right? We should always strive, because otherwise, what's the point?
Yeah, I mean, we were talking about the concept of race and how that affect and impact medical studies in general, not just the design of AI model, but clinical medical studies. Do you want to talk about that?
Yes. So we talked about this. So race, I think it's first for everyone to first understand that when we're talking about race, we're talking about a social construct. We're not talking about ancestry. We're not talking about genetics. We are actually just talking about a social construct that has hundreds of years of history attached to it that is important to understand if we're even trying to understand the importance of race and racial categories. I think that race plays a huge role when we're talking about bias, and many, it's in a multifaceted way. And so race has historically, for healthcare models and healthcare research, or any kind of epi research, has historically been treated as a basic categorical variable that people check the box for, and then we throw it into a model and we get a result out, and then we interpret it by race, or we interpret it in the context of race, without any true understanding of race and what we're even trying to interpret. And then we use race as a marker for a whole slew of things that is just not actually accurate or factual. So the point of that sort of brief, high level, comments is really for us to understand that when we're talking about race, we don't even know really what we're truly talking about. And if we're trying to use race as a marker for something else, then what we need to do is measure that something else. And I would go as far to say, as when we're measuring race and using it in models, we're likely measuring racism and the impact of racism on outcomes. And if we are really interested in understanding factors that play into our outcomes, we should measure those factors accurately. And we very rarely do. And hopefully science is moving towards us having a better understanding and measuring that. And you and I, when we were even talking about when race does matter, we were talking even about the wearable devices and how some wearable devices work better on certain skin colors or more accurate on certain skin colors than others. And it wasn't about race. And we did discuss how that's not race, that's melanin and that's skin color. And even within any socially constructed racial category, skin color covers the rainbow gamut. And so us having a much better understanding of what is it that we really want to measure, and just measure that, and don't use these other variables as a proxy. I'll also say in the healthcare record, race is not classified with any great accuracy at all, and people are often forced to either self-classify themselves, and we don't even know if they've always been self-classified or if somebody else classified them. So I just think that those are huge caveats for us to always think about when we're thinking about our models, when we're thinking about what they mean when we actually include race and how we interpret it. There are lots of guidelines, by the way, Stan, on how we should be interpreting race in research and in our models. And I encourage anybody to go through and dig up the literature and read those guidelines and kind of follow them when wanting to interpret and report the results.
Thank you. Thank you. We have another question from LinkedIn again. And guys, I encourage you to ask your question before the end of the show. So here, would an approach for image input data be different process than usual numerical data point to prevent the biases? I am not sure how to understand that question. I mean, would that be, I don't know if you want to give us more detail of what you mean, but maybe the idea that images are by nature more or less biased than numerical data. How do you see the
Numerical
question?
data. Yeah, I would like to, if there is a better, a little more context behind that question would be definitely helpful. I think that if it's a question about how the data are collected, perhaps, where image data would be not reliant on me providing you with information so much as you taking it from me, right? You're taking an image and using it. But I think we've seen a number of cases, and Stan, you probably know this better than I, where image data has been biased.
Yeah, I mean, we can think of the classical Google example of facial recognition, but maybe in this context, in a medical context, let's think of how AI can help surgeon detect tumors, for example, using heart or brain scan or heart scan and analyzing thousands of images. So again, in this context, yeah, we see the value of AI. Can this be biased? Well, I guess again, if you collect only a certain type of data, of images, then it might be biased toward one category of person.
Yes.
I don't know, but I think we're always back to the design of the model, the data gathering question.
Yes.
But yeah, feel free to provide more about your question if we are not.
And Stan, you said it exactly. It goes back to the design of the model, which it goes back to design, period. So I'd really love to have us go back to some principles of what is the question we want to answer and how do we answer that best. And usually if we have that nailed down well, what is the question? What do we want to test? How do we do that? Everything else tends to flow rather easily, but I think one of the things about AI people get all excited about is because they can just jump right into it and not have any great questions to ask and just see what kind of answers we get. And, it's kind of that theory-free analysis, but theory-free analysis is usually fragile because correlations don't always hold true for, repeatedly and reproducibly. So, but yes, I think that's an interesting point. I want to also say that these tools that we're talking about, and these clinical decision tools and predictive models, for the purpose of supporting the clinician and not for making the clinical decisions. I think the onus on the clinical decision making is always on the clinician, or the clinician, is on the clinician, and treatment options on the clinician and the patient. They have a conversation and they come up with treatment options. Any tool we use to predict anything is just a supportive mechanism for that relationship. And I think that's just important to keep in mind, because anything that we do produce, whether good or bad, is there to support a person who's making those decisions.
Right. So we have a little bit more info from the same user about the question.
Yes.
For example, an image, a medical image scan, brain or CT scan result versus Jericho numerical data from.
So, yes. So, again, I think both of those data points, they are supportive tools for the ultimate diagnosis. And so a blood test result specifically looking for tumor expression in the blood may have one specificity, sensitivity, and or positive predictive value, and a medical image scan of the brain is going to have another positive predictive value. And so the combination is probably often used to make an accurate diagnosis. The medical image scan, both of these are rather objective. So I think in the end, it's just about which one was a better predictor.
Okay, thank you. Jareen, we are getting at the end of this interview. Would you like to sum up what has been said as a general advice you might want to give to engineers who are listening today and who are thinking of how to best design their next model?
So I think that one thing is just to remember that anything that you produce is only as good as the data that you have, which I'm sure I'm speaking, preaching to the choir. So that's the first thing. The second thing around electronic health record is that data, because it wasn't collected for research, is just has a large number of problems that all need to be dealt with prior to building the model, and thinking through all of where the biases occur and how they occur, I think is really important before we ever build the model. Thinking about how those results are going to be interpreted in light of potential biases is also important. And throughout all of these stages, I think this is where that interdisciplinary team of individuals from across a series of diversity dimensions is important for us to be able to truly have a great understanding of what we're doing. And I think in the end, nobody wants to cause harm. We only want what we do to produce an improved health and well-being and quality of life of anybody that might be touched by this model or these models. Yeah, and just know that human beings are messy, and the data that we produce is messy. And I think if we just always keep that in mind, we'd be all right.
Great. Thank you so much, Jareen. Thank you for your time today. I think it has been a fascinating conversation. Thank you, everybody, for joining. Thank you for your questions. We will have more AI Talk Series with Neutigers, so stay tuned on our social media. Subscribe to our newsletter on newtigers.com in order to know of the next topic that we are going to tackle. And if you have any suggestion for topics, please email me at stan@newtigers.com. Jareen, thank you so much for your time today. Have a good day.
Oh, thank you very much.